and welcome to SCAI-TV, live at SCAI 2018. I'm joined today by Dr. Santiago Garcia, who presented one of the late-breaking clinical trials this morning. Thank you for coming here. Tell us about your trial.
My pleasure. Thanks for the opportunity. Today we discuss a subgroup analysis of a very large randomized clinical trial called PRESERVE. PRESERVE was published earlier this year, and it deals with a very common clinical problem in the cath lab, which is how to best prevent acute kidney injury. The focus of the present report is in the subset of patients undergoing primary angioplasty. The reason for the subgroup analysis is that these patients tend to receive higher volumes of contrast media and also have significant comorbidities that may exacerbate the deleterious effects of contrast media on the kidneys. So we conducted a subset analysis of about 1,100 patients enrolled in the study to try to assess the efficacy of IV sodium bicarbonate when compared to sodium chloride and acetylcysteine when compared to placebo.
So what were some of the challenges to that trial? And also, obviously, there's a lot of controversy. Some trials have already shown that fluids as well as acetylcysteine may not work in the subset. So was the thought that these would be higher risk patients and maybe in that subset it might work?
Correct. So some of the limitations of previous studies are, number one, they tend to include all comers, so patients that were perceived to be at very low risk of acute kidney injury. Also, they have used secondary endpoint measures like changes in creatinine, surrogate outcomes instead of patient-centered outcomes. PRESERVE took a more pragmatic approach. So the primary endpoint of the study was a patient-centered composite of death, need for hemodialysis, and a persistent decline in kidney function at 90 days. So those are some of the main differences between PRESERVE and other studies.
And so what did you find?
We found that these interventions do not make a difference, even when we look at the high-risk patients undergoing PCI. These patients, when compared to patients undergoing angiography without PCI, receive twice as much contrast media. The median volume was 160 mLs. 82% of them had diabetes, and the estimated GFR was 50, which corresponds to a creatinine of 1.5. Despite all these high-risk features, these interventions were ineffective in preventing the primary endpoint of death, a need for dialysis, or persistent decline in kidney injury that was present in about 3% across the board. Similarly, for the secondary endpoint of acute kidney injury, neither sodium bicarbonate nor acetylcysteine were better than the alternatives. The incidence of acute kidney injury was 11% at 30 days, and this is consistent with the high-risk cohort that was included in the study. So we concluded that these interventions are ineffective.
So clinical implications, does this put to bed these interventions for AKI?
I think it's time to add these two interventions to the long list of ineffective interventions we have for preventive acute kidney injury. We have now plenty of evidence to suggest that the standard of care should be sodium chloride as opposed to sodium bicarbonate, and there is no role for acetylcysteine. And this is probably good news for doctors and patients because bicarbonate is cumbersome. It doesn't come pre-mixed, it needs to be mixed in pharmacies, and it also has some incompatibilities with cardiac medications such as dobutamine and norepinephrine. So this will simplify the management of these patients.
This is reassuring. This is what we do nowadays, I think, from some prior trials, and probably the guidelines will be updated because of this.
Yeah, I hope so. I certainly hope so. That's our expectation.
Well, thank you. Some excellent work today. Congratulations on your presentation. And thank you all for being here at SCAI 2018.